Okay. Good morning, everyone. Welcome to this morning's webinar. So before we begin, we'd like to mention that this is our final webinar for the semester. I just want to thank everyone for joining over the semester, and we look forward to the next semester. And we are grateful for everyone's engagement over the past semester. So for today's webinar theme is urolithiasis, with particular focus on perioperative management of stone disease, as well as the principles of extracorporeal shockwave lithotripsy. So our first speaker this morning is Dr. Scheepers. Dr. Scheepers will be speaking on the principles of extracorporeal shockwave lithotripsy. Although it's one of the oldest minimally invasive treatment modalities for urinary stone disease, ESL continues to have an important role in appropriately selected patients. So understanding its principles, patient selection, and factors influencing success is fundamental in stone management with as well. So Dr. Scheepers, you're welcome to share your slides and begin with your talk.
Hi, good morning. Thank you so much for the opportunity. Let's see if we can get into this. One second. Good, there we go. Right. Good morning. So I'm Leo Scheepers. I'm one of the registrars at Tygerberg, and as mentioned, we will be going through the principles of extracorporeal shockwave lithotripsy. Looking at the introduction, shockwaves are generated by a source generated externally to the patient's body. Shockwaves are surfaces that divide material ahead, not yet affected by the disturbance from behind, which has been compressed by the energy being input from the source behind it. Lithotripters use a weak, non-intrusive wave that are generated externally that is transmitted through the patient's body and then focused onto the stone. Looking at the mechanisms of fragmentation, stone fragmentation occurs through mechanical stress produced either directly by the shockwaves or indirectly by the collapse of the cavitational bubbles. Shockwave dynamics looks at a single shockwave pulse leading to which lasts approximately 4 microseconds. It consists of two distinct phases: the compressor phase as well as the tensile phase. The compressor phase is short, has a steep, beg your pardon, uh, looks like it wants to just want to pause it. Looking at the compressor phase, it has a short, steep front, reaching pressures of approximately 40 megapascals, as your tensile phase is longer, has a lower amplitude with a pressure wave of approximately -10 megapascals. The primary theories of fragmentation, these include spalling, which is the coalescence of microcracks leading to comminution; superfocusing, this is the amplification of stresses within the stone dictated by specific geometry; shear stresses, this is transverse waves that result in molecular shifting within the stone; compression, these are circumferential compression factors caused by the difference in sound speed between the stone and the surrounding fluid; acoustic cavitation, this is the collapse of cavitational bubbles generating intense localized pressures on the surface of the stone; dynamic fragmentation, this is the accumulation of damage through the growth and coalescence of flaws caused by the tensile and shear stresses. Looking at the components of a ESL setup, we're going to look at the generator types, the focusing mechanisms, as well as the coupling mechanism and imaging systems. ESL systems are categorized by the modality of shockwave generation. Each type offers a distinct clinical advantage as well as a disadvantage. The three main types is electrohydraulic, electromagnetic, and piezoelectric. Electrohydraulic spark generators uses a high voltage which is applied to two opposite ends of an electrode. This results in an underwater spark discharge, which then vaporizes bubbles and this causes an expanding shockwave to be caused. The shockwave is a spherical shockwave and starts at F1 and is focused onto F2. As you can see, the positioning of F1 and F2 is important to allow for adequate focusing of the shockwave. The electromagnetic forms, these are produced by magnetic fields either in a flat or a plane, or can be round and cylindrical. Electric current is passed through a coil. A strong magnetic field is produced. This then either pushes onto a diaphragm, which produces a shock wave. Flat planes moving against the water generates a pressure wave, focused then by acoustic lenses. For your cylindrical forms, the magnetic fields between the cylindrical coil surrounded by a membrane that is pushed away from it. These waves are then reflected by a parabolic reflector and then focused onto F2, which is your target. Piezoelectric generators, where piezo means pressure, electric charge accumulates on the solid material, such as crystal or ceramics, which produces a mechanical energy. In essence, by applying electricity to either crystal or ceramics, it causes it to vibrate at a certain frequency. Thousands of these piezo ceramic elements are then positioned on a reflector or a spherical dish, each producing a powerful shock that is then focused. Looking at your imaging systems, commonly fluoroscopy and ultrasound or combination of the two is used. Fluoroscopy is used at different angles. It can be either from two different sources or from a single source that is rotated. The benefit is that it is familiar to urologists. It's able to visualize radio-opaque stones throughout the urinary tract, and then with the aid of contrast, can be used to increase its anatomical detail. The disadvantages is, however, that it does produce radiation to staff and to the patient. It has a high maintenance demand, and it is not able to visualize radiolucent stones without the aid of a contrast media. Ultrasounds, it does not produce any radiation. It is able to visualize radiolucent stones, but the disadvantages outweigh the benefits. It needs more highly trained operators, and it can be difficult to see stone fragments if there is already an indwelling ureteric catheter, or if the stone is lower down in the middle or lower ureters. Looking at your coupling mechanisms, you can either have a water bath or a dry method. The water bath is considered to be an older method, but theoretically offers more reliability, as there's less bubbles that can form between the source and the patient. Your dry form is more modern. A water-filled drum or cushion with acoustic gel or rubbers can be added to increase the reflective surface, and is less likely to develop bubbles in that medium. Your indications, your primary indication is most successful when the following criteria are met: stone size, typically less than 1 centimeters. If the stone location is in the upper or middle pole or in the proximal ureter, and then the composition, favorable Hounsfield units and non-resistant stone types. In addition to that, you can use scoring systems like the double D score, which predicts stone-free rates. It is a CT scan-based scoring system looking at the stone volume, stone density, and skin-to-stone distance, with a volume of less than 150 giving you a score of 1. A stone density less than 600 Hounsfield units is another point, and a skin-to-stone distance of less than 10 centimeters. This correlates roughly to a score of 3, leading to a stone-free rate of over 96%. Just of note is the resistant types. These will be your calcium oxalate monohydrates or your cysteine stones, which tend to be more difficult to break. Looking at indications for pre-treatment stenting. Stenting prior to ESL is indicated in some specific scenarios. These include patients with solitary kidneys, a stone size greater than 1.5 centimeters, patients with refractory renal colic or renal insufficiency. If you intend to do bilateral procedures, in patients with infections associated with obstruction, and for stones that are poorly visualized. Clinical indications. The EUA, as well as the American Urology Association, tends to look at the treatment selection based on stone burden. For stones less than 2 centimeters that are not in the lower pole, Shockwave lithotripsy should be the first line alongside URS. While there are less complications with Shockwave lithotripsy, patients must be informed that URS typically yields higher stone-free rates. If we look at stones in the lower pole, stones less than 1 centimeter, you can use either Shockwave lithotripsy or URS. For stones greater than 1 centimeter in the lower pole, Shockwave lithotripsy is not recommended as the first line treatment. The evidence indicates that a stone-free rate of only 21% with shockwaves in these cases compared to 91% with percutaneous lithotripsy and percutaneous nephrolithotomy, I beg your pardon. For stones greater than 2 centimeters, shockwave is not considered as a first-line option, and PCNL is preferred in these cases. Cross-sectional imaging is vital for determining ESL candidates. As we've mentioned, we'll look at your stone density, preferably less than 900 Hounsfield units. Patients with a skin to stone distance less than 10 centimeters, and the stone is not located in the lower pole. Safety considerations, looking at absolute contraindications, pregnant patients due to the potential effect to the fetus, uncontrolled coagulopathy or the use of antiplatelets or anticoagulation medications, severe untreated hypertension, aortic aneurysms more than 4 centimeters close to the stone, untreated urinary tract infections, severe skeletal malformations preventing targeting of the stone, and if it's unable to position the patient correctly, severe obesity preventing targeting of the stone, and anatomical obstructions distal to the stone preventing fragmentation clearance, as well as tumors or if the lung is in the path of your shockwaves. Your relative contraindications can be specific stones types. These will include cystine or matrix stones, anatomical features like a horseshoe kidney or an ectopic kidney, complex internal drainage, as an example here would be infundibular stenosis or poorly controlled hypertensives. Looking at potential complications for ESL, cardiac arrhythmias occur in about 9 to 59% of cases. Most of these are treated by temporary pause or by cardiac gating. Renal hematomas occur anywhere between 1 and 20% of cases. Risk factors include advanced age, hypertension, obesity, as well as diabetes. Stonestrasse or stone street or fragmentation in the ureter. These can occur normally between 1 to 4% of cases, but increase to between 5 to 10% if the stone burden exceeds 2 centimeters. Additional to that, tissue injuries, these tend to be rare, but can involve the liver, colon, spleen, pancreas, and these are normally as a result of the cavitation-induced vascular rupture. Looking specifically at acute kidney injuries, these can include subcapsular hematomas, hematuria, internal or perinephric edema, acute renal failures as well. Chronic renal failure may lead to accelerated hypertension, permanent decrease in the renal function, and an increased incidence of recurrent stone due to residual debris. Your extrarenal traumas, potential damage to the liver, as we've mentioned, the liver, the pancreas, gastrointestinal tract, colon, as well as skeletal injuries may be possible. And then there could be a 3-month decrease in semen quality for stones in the distal ureter that have been exposed to as well. Looking at factors influencing the degree of renal trauma, your aggravating factors, these will include the number of shocks applied, the short duration for the administration of these shocks, if a high voltage was used. First generation devices tend to be more aggressive, leading to these renal traumas. If you have a small kidney and applying the same dose in elderly patients or patients with pre-existing renal impairment, Your mitigating factors could be a pre-treatment shock administration of between 100 and 500 shocks at a low energy. Treatment at a low rate of shocks delivered, approximately 60 to 90 shocks per minute. Risk factors for hematuria. Patients who are at risk tend to be at the extremes of age. These will be juvenile or elderly patients, patients with obesity, pre-existing hypertension, coronary artery disease, or diabetes, and then patients receiving coagulopathy or thrombocytopenia, cytopenic patients. Strategies for optimizing outcomes. So looking at our techniques, looking at the coupling quality. We know that air pockets between the generated source and the patient body can degrade the quality of it. So it's quite important to make sure that if you're using a coupling, your coupling media, that there should be no large amounts of air pockets in it. Your shockwave rate. We are aiming for a shockwave rate between 60 and 90 shocks per minute. And then looking at the voltage ramping, so to gradually increase the number over the first 4 minutes, these tend to decrease the incidence of renal vascular injury. And then going on to your post-procedural management, while JJ stenting is not shown to improve stone-free rates for uncomplicated cases, medical expulsion therapy using alpha blockers have been shown to improve fragment clearance, decrease pain, and reduce the time to clearance. Additionally, mechanical percussion, diuretics, and inversion therapy may further assist in the clearance of residual fragmentation. Looking into the future, research has been leading towards burst wave lithotripsy and ultrasonic propulsion. These investigational techniques utilize handheld probes and real-time ultrasound. For your burst wave lithotripsy, uses a narrowband burst of low peak pressure, around 4 to 8 megapascals, over a long duration, which is different to the broader pulses seen by shockwave lithotripsy in the classical sense. The advantages can be often performed without the need for anesthesia or sedation due to the low peak pressures produced. It produces less cavitation and yields more uniform stone fragments. And then finally, your ultrasonic propulsion. This technique is using focused ultrasound pulses to reposition stones or fragmentation within the kidney or ureter, facilitating the natural passage. Thank you very much.
Thank you, Dr. Scheepers. Do you have any questions on the floor from our side? Let me just check if there are any questions in the chat. Nothing so far. I wanted to ask Dr. Scheepers, at your facility, with your ESWALs, what type of anesthetic are you giving these patients? Are you doing sedation for them or general anesthetic? And then also in terms of stenting, do you ever pre-stent patients, or is it that you would just stent them if it is that it's necessary, sort of post-procedure?
So at our facility, we use a general anesthetic for all our patients, provided they are able to handle general anesthetic. As far as JJ stenting, we tend to follow the guidelines here. We are fortunate enough that we do have the facilities to stent if needed on the day. So we tend to stent our patients if needed.
Okay, thank you. Any other questions on the side? Nothing at the moment. Thank you, Dr. Scheepers. If there are
Thank
any
you very
questions,
much.
I'll ask you in a bit, eh?
Perfect.
Okay,
I'll
so
sit tight.
thank you. So our next speaker this morning is Dr. Adam. He'll be speaking on post-operative care and complications in stone surgery. So we know that with the advances in endourology, and it's making stone surgery increasingly safe and effective. So it's important for us to recognize and manage these post-operative complications to have good outcomes for our patients. So Dr. Adam will be taking us through potential complications and how we manage them from a stone point of view. So Dr. Adam, you can share your slides and you can begin with your talk.
Yes, I'm here. I'm trying to share my screen.
Perfect. You can share your screen.
Hello, can you hear me now?
Can hear you. Is there any way that you can make your screen full screen? It's very small.
Oh, okay.
There we go.
Yes,
That's
can you hear
perfect.
me and
That's
you can
perfect.
see my screen?
We can hear you. We can see you clearly. You can begin.
Okay, thank you. Okay, thank you. Good morning, everyone. This is Dr. Ihab Adam. I'm a supernumerary registrar here at St. Aidan Hospital in Durban, University of KwaZulu-Natal. Thanks for having me in this morning, and this is my first presentation is in this lovely platform. Today I will be speaking about urolithiasis, post-operative care and complications. And I'm going to go through introduction, and I will give a brief refreshment about stone management. Then I will give details about general complications, then procedure-specific complication. Then I will conclude on my topic. So treatment of urolithiasis decision is directed by the anatomical site and size of the stone and density. And minimally invasive surgery aim to maximize the stone-free rate and to decrease the complication. Then emergency decompression with the JJ stent or nephrostomy is mandatory for the obstruction. And in the infected system before the definitive surgery. So generally, we can classify manage surgical operation of the urology system in upper tract and lower tract. In upper tract, depends on the stone size. If the stone size is less than 10, then we can give option for observation. And the first line option here is also as well as discussed by my colleague previously. And if the stone size is between 10 and 20, the standard approach is URS or as well. And it will be a bit difficult in the lower. Hello? Yes. And it will be a bit difficult in the lower pool. In the lower pool, because in the lower pool anatomy is impaired. It's a depending area, and there is difficult for the fragment to be clear. Then, if the stone is more than 20 millimeter, and in the situation of staghorn calculi, so the gold standard is PCNL. And standard PCNL for high stone volume, it's the gold standard. Then mini PCNL for the for smaller stone to decrease the complication. And we can also use URS if there is a contraindication to use the PCNL. And for the stones in the ureters, in the proximal ureter, if the stone is less than 10 ml, so we can give a trial of medical expulsive therapy with alpha blocker and painkiller, and we can also use as well or URS as acceptable surgical intervention. And if the stone is more than 10 ml, then URS is preferred due to high immediate stone-free rates compared to as well. Then in the distal ureter, also if the stone is less than 10 ml, medical expulsive therapy can be applied, and if the stone is more than 10 ml, then millimeter, then semi-rigid URS with the lithotripsy is a standard of care. Then in lower urinary tract, especially in the bladder, endoscopic cystolithopexy or lithotripsy can be applied, and this depends on the stone size, and we also need to clear the cause of that obstruction or the cause of the stone formation during the sitting of that operation. Then if the stone is in the urethra, so usually we intervene because sometimes it's associated with the urinary retention. Then we can push the stone back and try to lithotripsy or cystolithopexy. Then in in rare locations like seminal vesicles, so it's extremely rare presentation, and usually the patient present with the hematospermia, and we manage it with transurethral seminal vesicoscopy for fragmentation. And for the stone in the scrotum, it's typically benign, and most of the time it's asymptomatic, and it can be cleared during hydrocele or during the scrotal exploration. Now I'm going to jump to the general complication, and usually we use Calvin-Dindo classification to classify the post-operative complication. And Calvin-Dindo classify post-operative complications into 5 categories, where the first category, when there is no need for surgical or pharmacological intervention except for physiotherapy or electrolytes or symptoms management. Then grade 2, when there is need for antibiotic or TBN or IV or active management, pharmacological management. Then grade 3, when there is a need for surgical intervention, and it will be 3A if we intervene with the local anesthesia on that patient, and it's grade 3A when we do the procedure under general anesthesia. Then we have grade 4 complication, and 4A when there is a single organ failure, and grade 4B when there is multiple organ dysfunction, and grade 5 when the patient dies. So most of the common complication of stone management is the pain, and the pain can be classified from no pain till worse or severe pain, and it can be classified into mild, moderate, or severe, or even we can ask the patient to give a scale from 0 to 10, and accordingly we can treat that pain. And we have the multimodal analgesic approach, and we can start with non-steroid anti-inflammatory drugs and acetaminophen. And intra-op, we can insert epidural, or we can give local, or we can even give a PCA. And the protocol is to decrease the narcotic use, which has a high addiction rates, but still, if the pains can't be controlled with other options, we can still add the narcotic. And then there is also a rule for alpha blocker to relax smooth muscle in the urinary tract and prostate to prevent post-operative urinary retention, especially, and to reduce discomfort from internal stents like the double J stent. Then also one of the worst complications of stone management is infections. And it can be due to UTI, which is spread from the biofilm when we break down the stones, or it can be spread from urosepsis, which is the bacteria that spread from the urinary system to the general circulation. And this situation, the patient come with a severe systemic response to infection. And we can apply the first golden hour sepsis management according to SSC, and we can use SOFA score to classify these patients. Then we can start them on antibiotic and screen early an antibiotic and treat them accordingly. Then, sorry, I will come to that slide. Then we have, I have to also mention management of the catheter and drain, because most of the patients post operation, we discharge them from the operative room with the Foley catheter. And usually we leave it there for 24 to 48 hours to reduce the complication, unless there is a complex or indication to keep the catheter. And we need also to monitor the nephrostomy tubes. We need to monitor the outputs and the volume and the color of the urine. And also we need to monitor the stent and ensure the patient education about the stent symptoms. And we need to pay attention for the drain, especially in the on post-open surgeries. Also, one of the complications is hemorrhage or hematoma, which is a heavy persistent bleeding and urine that become and when the urine become bright red, thick, or contains large blood clots. And when there is a systemic symptoms like a dizziness, light headache, chest pain, or shortness of breath. Then when there is a severe pain, and when there is a severe sign of shock. And I put this diagram here, and it shows that whenever we suspect that patient has hemodynamic, we can classify them into two categories, either unstable. So if they are unstable, we can resuscitate them. Then if they respond well to the resuscitation, then we can investigate further on that cause and to control that bleeding. But if they're not stable, then we can take them to theater. And when they are stable, we can investigate the cause for that bleeding, and it can be luminal or extraluminal. And we can then do CT angio, and then we can treat them accordingly, either with conservative management or angioembolization. So also one of the complications is urinoma, and usually manifest after a specific stone intervention due to structure damage or intense pressure dynamics. So it's an urgent diagnosis, and before intervention, we need to confirm the fluid collection is actively leaking urine. And the image gold standard is a contrast enhanced CT scan with delay phase. And it's used to track contrast fluid spilling out of the urinary tract. Or we can do also fluid biochemistry to if the patient still has the drain, and we send it for creatinine level. Then we also need to reestablish the urinary flow, either with JJ stent or nephrostomy. Then we need to manage the urinoma or collection. They can either go to conservative management if the urinoma is very small and sterile. And for large, painful, and extending urinoma, we can drain them percutaneously. Then we need also to control the infection with antibiotic therapy, and on the final resort, we can take them for surgical open repair. One of the complications also is the perforation, and it either can be in ureter, and it can lead to urinoma, sepsis, or stricture, or ureter avulsion. Then also we have the bowel perforation, and it can cause peritonitis, nephrocolic fistula, or abscess formation in retroperitoneal space. And also there is a percentage of recurrence even after clear the stone. And stone composition significantly affect the 5 years surgical recurrence, with non-calcium oxalate stone forms at a higher risk of recurrence. And also one of the complications is ureter stricture, and it's due to repeat aggressive ureteroscopic micro trauma, and it can lead to localized scar tissue formation and narrowing of the ureter. And we can use AAST, American Association of surgical trauma, and we grading the classification, or we can use taxar and traumas classification to classify the injury of the ureter. And according to that classification, it can be low-grade injury, which doesn't need intervention. Then a high-grade injury, which needs intervention either with stents or nephrostomy, or grade 4, when there is a total ureter avulsion. And also one of the complications, also ureter avulsion, which is the most severe form of ureter injury and characterized by complete tearing or separation of the ureter from its attachment. And when we suspect that diagnosis, we need to immediately identify the avulsion, and we need to stop the surgery. We need to stop the irrigation fluids. We need to see what's happening exactly, either with the scope. Then we need to make a diversion, either with PSA nephrectomy. Then we need to reconstruct that ureter. And if it is in the upper ureter, we can do ureterostomy or ileal interposition. And if it's in the lower ureter, we can do ureteroneostomy or Sowers Hitch or Bowari flap. And if it's complete or extensive avulsion that can be repaired from the upper options, we can do autotransplantation, and we can do nephrectomy as the final resort. And long-term medical management and complications. So patient with the long-term thiazide, we should pay attention that they may develop electrolyte disturbance like a hypokalemia, hyponatremia, and hypercalcemia. They can also develop chronic hydronephrosis and renal atrophy. They can have recurrent UTI. They can have VUR, renal fistula, and they can have also gastrointestinal distress. Now I will jump to specific procedure complications. With I'm not going to give much talk about ESL because my colleague just spoke about the complications a few minutes ago, and it can be in the short term, on the long term. And he also spoke about the rare complications. Yes, and then regarding the PCNL, which is percutaneous nephrolithotomy, it can have acute complication with severe hemorrhage, and that mostly can be due to puncture or dilatation of the kidney, can cause tear of renal artery branch and can lead to form of arteriovenous fistula or pseudoaneurysm. And usually we treat that with the renal artery angiogram and transcatheter embolization. Then also one of the acute complication is visceral and bowel perforation. It's a rare case, and it can affect the loop of large intestine, and it can cause it's a rare case, and loop of the large intestine colon sits behind the kidney in the retroperitoneal space, and the puncture needle can pass through that colon. And then management is when we identified it appropriately, the tract is diverted and general surgery is consulted. If found post-operative fever, stool, or stool in the nephrostomy tubes, it's required urgent colonoscopy or bowel repair. Then there is a collecting system injury. It can be tear or perforation, and it can lead to urinoma, and we can treat that one with double J stent. Then there is a risk of pleura and thoracic injury, and this can lead to pneumothorax or hemothorax, and we can treat that one with the chest tube or pleura drain. Then in long term, patient can have urosepsis or systemic infection, and also they can have PUJ obstruction, and they can have form nephrostomy tract fistula, especially if there is obstruction. And regarding URS, which is ureteroscopy complications, it can be immediate and long-term complication. In immediate complication, we spoke about pain management, and they can have also sepsis, and they can have ureter injury with perforation and urinoma formation. And in the long term, there is a risk of stent-related symptoms, and that can be managed with alpha blocker or anticholinergic and painkiller. And there is also a risk of ureter stricture. And I need to also mention the forgetting stents, which is a failure in post-operative tracking where an internal double J stent is left inside the patient past its maximum safe duration, which is usually 3 to 6 months. And management for that patient, it's required complex multi-stage surgeries because they may develop encrusted stents with new stones formations. And other complication we can have from URS is stent migration or fragmentation while we're pulling the stent, an intraoperative instrument failure, and also we can have reflux and bladder neck contraction and mucosal tear. Then lastly, when we do open or laparoscopic surgery, we need also to take care of the wound to prevent wound dehiscence or scar, and minimize risk of scar or wound infection. Then we need to monitor also for our surgical drainage management. We need to monitor them and biochemical fluid check. If the urine drain output is high, then we need to remove them whenever it's possible. And we also shouldn't forget about our Foley catheter and our double J stent. And one of the most common, one of the most dangerous complications post-open surgery is DVT and PE. That's why we use the Caprini score for prophylaxis, and it's weigh the benefits and risk of using the thromboprophylaxis. And it classified the patient into moderate, high, and lower risk. And it starts from, for the lower risk, we can start with early ambulation, and we can choose multimodal management for the patient with the high risk. Then I should mention also urine leak or urinoma and pain management and mobilization. Then we have also the paralytic ileus, and we need to enforce power rest and implement intravenous fluid hydration and correct electrolytes implants and encourage active ambulation and avoid early opioid escalation. And we also have to utilize the prokinetic agent in paralytic ileus patient. Then in general, for all post-stone management patient, we have to monitor them for further complication, and we need to follow them in short term with the stent removal and drainage removal, and we need to do initial arrangement to confirm that the stone is cleared. And for long term, we need to go through surveillance to prevent the stricture and to prevent further damage to the kidneys. So in conclusion, urolithiasis or urinary tract stone disease required structured post-operative management to facilitate stone fragment clearance, ensure safety, and prevent recurrence and complications. Yes, that's my references, and thank you, everyone.
Thank you for the talk, Dr. Adam. Just a question from my side with regards to URS and PCNL. Do you have any sort of pre-operative or intraoperative risks for sepsis with these procedures? And then also I wanted to ask you, in terms of length of procedure, do you have any cutoffs as to what would be sort of safe or what increases your chances of sepsis post-procedure?
Thanks for the question. So yes, before the procedure, we need to be sure that the patient doesn't have UTI or sepsis by clearing the urine MCNS. And also we need to monitor the other comorbidities and maximize the other comorbidities like diabetes and blood pressure. And we also can add intraoperative antibiotics that will reduce the risk also for sepsis.
Okay, thank you for that.
Then regarding the length of okay.
You can go ahead. The length you said, we just missed the part of that.
Okay. Okay. So regarding the length of the procedure, I'm not sure about my answer, but I think it's not beyond 60 minutes.
Thank you for that. There's nothing really in the guidelines that I could find in terms of a specific time. The guidelines just mention that obviously the longer, the more risk of sepsis. Some studies have shown between 60 and 90 minutes maximum, because obviously the intraoperative risks include obviously treating a positive urine, like you mentioned, but also the use of irrigation prolonged, increased injury to the urinary tract, bleeding and hypothermia as well. And I think with prolonged procedures, obviously your chances of all of that increases. Just in terms of the irrigation, we obviously know that a lot of work as of recent has been put into decreasing intrarenal pressure. So I think with the suction catheters and so on, that's sort of been the way forward to try and decrease that amount of intrarenal pressure and potentially the risks of sepsis post um, uh, these procedures. Do you have any other questions in the room? Anything in the chat? Let's have a look. I don't think we have any other questions. Thank you so much, Dr. Adam, for your talk. I would like to say thank you to Dr. Scheepers and Dr. Adams this morning for such excellent presentations. Thank you, everyone, for joining us this semester, all the presenters, everyone who joined and engaged in the talks. I just want to remind everyone that SAUA would be in October. So registrations open up on the website, and abstract submissions are also opened up for everyone to do so. Um, yeah, we look forward to seeing you all next semester for the next series, and have a good break. Thank you.
Thank you.